Okay, so welcome to this next video in which we're discussing the use of the glucocorticoids to treat asthma. Okay, so we're currently talking about the pathology of asthma. Okay, so we've seen how the primary exposure to the allergen causes a type 1 hypersensitivity reaction where you launch a humoral adaptive immune response against the allergen and end up producing immunoglobulin E molecules that are targeted against this allergen. These IgE molecules end up mounted on Fc epsilon R1 receptors, which are on the surface of mast cells, and here they will remain for months and months and months, basically, long after the IgE has gone down in the blood and the plasma cells have also gone down in the blood, which were producing the IgE. Okay, now, if you get exposed to the antigen again, or the allergen again, whilst you still have IgE molecules mounted on your mast cells on Fc epsilon R1, then what will happen is the allergen will stimulate these Fc epsilon R1s by binding to the IgE molecule mounted on them, and this will trigger activation of the mast cell. Now what happens in mast cell activation is calcium in the cytoplasm ends up going up, and this causes firstly degranulation of the mast cells, so the release of histamine, and then it also activates the enzyme cellular phospholipase A2, which breaks down phosphatidylcholine molecules into lysophosphatidylcholine and arachidonic acid. The arachidonic acid is then used by the enzyme 5-lipoxygenase, which also is activated by calcium and moves from the cytoplasm to the inner leaflet of the phospholipid bilayer, and then can act on the arachidonic acid in the membrane. Okay, so it's going to convert the arachidonic acid first into 5-hydroperoxyicosahexatetraenoic acid, and then onwards to leukotriene A4. Okay, now leukotriene A4 can then be converted into one of two things. It can be converted either into leukotriene B4 by the enzyme leukotriene A4 hydrolase, which is a cytoplasmic enzyme, and I should have mentioned that leukotriene A4 comes out of the phospholipid bilayer and goes into the cytoplasm so that it can be acted upon by these two cytoplasmic enzymes. Or it can be converted into leukotriene C4 by the enzyme glutathione S-transferase. Leukotriene C4 can then go on to be converted into leukotriene D4, and then even further it can go into leukotriene E4. Okay, now all three of these separate stages are all going to be secreted from the mast cell, and together these three are collectively known as cystenyl leukotrienes. So let me go on to the next page and I'll talk about this. So the cystenyl leukotrienes is the name given to the collective name given to these three separate leukotrienes. So it's the name given to leukotriene C4, leukotriene D4, and leukotriene E4, because effectively they all do the same thing. And for short, cystenyl leukotrienes is just denoted as cis and then LT, like that. So that should be read as cystenyl leukotrienes. Okay, so these activated mast cells then are going to secrete histamine, cystenyl leukotrienes, and also leukotriene B4, which is not counted as a cystenyl leukotriene. Okay, so the activated mast cells are secreting into the lamina propria three pro-inflammatory mediators that we have seen so far. So one is histamine, which is released by the mast cells when they degranulate. So they already have the histamine stored in these histamine granules, and all they have to do is release it. Okay. Then you release leukotriene B4. Okay. You also release these three cystenyl leukotrienes. Okay. So cis-LT, and then finally you also release one more, which is tumor necrosis factor alpha. So the mast cells are also activated into producing TNF alpha, and this is a protein which they have to actually produce from scratch, so it takes them longer to produce TNF alpha. Histamine is going to be produced the quickest because it just has to be released. These two are going to take slightly longer, but they're still extremely quick. TNF alpha is a protein and is going to take a long time to make. Okay, so this one's going to be secreted much later. Okay, so Now, these four are going to be responsible for the asthmatic attack, okay? So these four going up in the lamina propria of your airways, and let me stress that this will be happening in all your airways. Everywhere where the allergen got to is going to undergo this same reaction, basically. So it could be happening potentially in every single bronchus you have, basically. Okay, now, what happens? Well, the asthmatic attack itself can be divided into two separate phases. Firstly, it can be divided into the immediate phase. Okay, so the immediate phase is the phase which happens quicker, so it will happen within a few minutes, basically. And in the immediate phase, what happens is, firstly, histamine goes and acts on the bronchial smooth muscles. So remember, however long ago it was we discussed this now, that underneath the lamina propria was this layer of smooth muscle cells here, okay? And histamine is going to diffuse back from the lamina propria where it's being produced, and it's going to go to these bronchial smooth muscle cells, okay? And there it will act on receptors on the surface of the bronchial smooth muscle cells, okay? So let's say this is a bronchial smooth muscle cell here. These bronchial smooth muscle cells have on their surface the H1 histamine receptor, which is a GQ coupled receptor. Okay, so this is the histamine 1 receptor, H1. Okay, so histamine will come, bind to this H1 receptor. It will activate the GQ pathway, which will cause the release of calcium from the intracellular stores within these smooth muscle cells, and that will cause the contraction of these smooth muscle cells. Okay, so histamine is going to cause contraction of the smooth muscle cells. In addition, the cysteinyl leukotrienes that the mast cells are releasing are going to act on cysteinyl leukotriene receptors on the surface of the smooth muscle cells. Okay, so let me draw this here. So, this is a cysteinyl leukotriene receptor. Okay, now, the main cysteinyl leukotriene receptor that is very, very important on the surface of the bronchial smooth muscle cells is cysteinyl leukotriene receptor 1, but you also have cysteinyl leukotriene receptor 2. So there are two cysteinyl leukotriene receptors, both of which are expressed on the bronchial smooth muscle cells. Okay, and we think cysteinyl leukotriene receptor 1 is slightly more important than the cysteinyl leukotriene receptor 2 because the competitive antagonists, the anti-leukotriene drugs, which are competitive antagonists for the cysteinyl leukotriene receptors, and are specifically competitive antagonists for the cysteinyl leukotriene receptor type 1, these are just competitive antagonists for the cysteinyl leukotriene receptor type 1 rather than for the cysteinyl leukotriene receptor 2. And as I say, they are very effective at reducing asthmatic attacks. Okay, so the cysteinyl leukotrienes, however, are going to come and bind to these cysteinyl leukotriene receptors which are on the surface of the smooth muscle cells, and this again is a GQ coupled receptor and will lead to the release of intracellular calcium stores. So calcium will go up within the cytoplasm of these smooth muscle cells, and that will lead to contraction of the smooth muscle cells. Okay, so calcium goes up, and this leads to contraction of these smooth muscle cells. Okay, and we discussed that when you get contraction of these smooth muscle cells, what that is going to lead to is it's going to lead to the constriction of those smooth muscle cell rings that surround the bronchus. And when these rings of smooth muscle cells constrict, that's going to cause constriction of the whole bronchus and the lumen of the bronchus, and that's going to narrow the airways, basically. Okay, so that's part of the immediate phase of the asthmatic attack. Okay, now there is another thing which contributes to the immediate phase of the asthmatic attack, which is that you're also going to initiate an inflammatory response. Okay, so histamine is incredibly powerful at doing this. So not only will histamine and the cysteinyl leukotrienes diffuse back to the bronchial smooth muscle cell layer, in addition they'll diffuse over to these blood vessels which are in the lamina propria. Okay, now you have 3 different types of blood vessel within the lamina propria. Okay, so the 3 different types of microvasculature, which I'll just go through here. So you'll have terminal arterioles, which are the tiny little arterial blood vessels, which are just before you branch into capillaries. So here you can see the terminal arteriole branching into capillaries. So this is the terminal arteriole here, okay? And the importance of the terminal arterioles is that they have a layer of smooth muscle cells which surround them, okay? So this is a terminal arteriole. And then you'll also have capillaries. So the terminal arterioles quickly divide into capillaries like so. Okay, so here are the capillaries, and the capillaries reconverge into a post-capillary venule. Now, capillaries are tiny little blood vessels. They are literally 1 cell thick, okay? And their walls consist of a basement membrane with endothelial cells sitting on them, okay? And then after the capillaries, you have what is known as a post-capillary venule, okay? And a post-capillary venule is effectively just a big capillary. It has the same wall structure as a capillary. You just have a basement membrane with endothelial cells sitting on the basement membrane, and that's the whole structure basically. You have nothing else. Okay, so very, very thin walled blood vessels, capillaries and post-capillary venules are. Whereas terminal arterioles are slightly thicker. They have a layer of smooth muscle cells around the basement membrane. Okay, so these are the 3 types of microvasculature you have within the lamina propria, and it's important to clarify when you're talking about the terminal arterioles and post-capillary venules. It's important to put things like terminal arteriole to tell people that you mean an arteriole just before it branches into capillaries, because the term arteriole can actually cover a huge scope of different sized blood vessels, okay? And again, venule as a term can cover a huge scope of different sized blood vessels. So it's important to put the qualifier post-capillary venule to make sure people realize you mean the venule that is just after capillaries have reconverged. Okay, now histamine is going to act on endothelial cells that are within these 3 different types of microvasculature, which just means these tiny little blood vessels within the lamina propria. Okay, and what it's going to cause is it's going to cause type 1 activation of endothelial cells. Okay, so it will lead to type 1 activation of all of these endothelial cells. Okay, and now what happens is that these type 1 activated endothelial cells, they're going to begin an inflammatory response. So what are the components of the inflammatory response? Well, firstly, what's going to happen is the type 1 activated endothelial cells are going to start producing vasodilatory substances. So they're going to produce substances such as, let me put this down here, okay, I'll put it down here. Okay, so they're going to start producing things like prostacyclin, prostaglandin I2, and they're also going to start producing things like nitric oxide, and these will cause vasodilatation of the terminal arterioles, because they will diffuse back to the smooth muscle cells that surround the terminal arteriole, okay, and they'll cause relaxation of those smooth muscle cells, and that will dilatate the terminal arterioles. So you'll get vasodilatation, okay. You're also going to get type 1 activation of the endothelial cells in the capillaries and the post-capillary venules. Now here what it leads to is it leads to endothelial cell contraction. Okay, so the endothelial cells shrink a little bit and open up gaps between neighbouring endothelial cells, and this makes holes in the walls of your capillaries and your post-capillary venules, which leads to the formation of an inflammatory exudate, because fluid from within the blood vessels will leave the blood vessels through these gaps in the endothelial cells, and then they will go into the interstitial fluid, and this new fluid causes swelling of the area. Okay, so it's going to cause swelling of the interstitial fluid, and this, remember, is happening within the lamina propria. Okay, so you are going to get swelling of the lamina propria. So this lamina propria is going to start to swell, and that's going to push out on the basement membrane, which has these epithelial cells in. So that's going to push the basement membrane and the epithelial cells inwards, and that also is going to reduce the size of the lumen of the airway. So two things are going to reduce the size of the lumen of the airway. You've got the contraction of the smooth muscle cell layer, which is narrowing the airway, and then you've also got this swelling of the lamina propria due to the formation of this inflammatory exudate, which is also going to push in and obstruct the airway. Okay, so you've got two things working against you here. You've got the smooth muscle cell contraction and the inflammatory response. Now, of course, this is all happening because the mast cells are trying to protect you. The mast cells think that they have found a highly dangerous antigen, okay, from some highly dangerous pathogen. Of course, the fact that the allergen is innocent is what makes this story so tragic. But they think they found something extremely dangerous, okay, so they are launching this inflammatory response to try and bring things in that are going to help destroy the invading pathogen, okay. So the inflammatory exudate is full of proteins, basically, from the blood, such as complement proteins, coagulation factors, the components of the kallikrein-kinin system, all of which are going to help with destruction of the pathogen, okay? So complement can actually set up the complement cascades, which will directly attack the pathogen. The coagulation factors will set off the coagulation cascades, which will produce a fibrin meshwork everywhere, which will help to contain the pathogen. And the kallikrein-kinin system will then produce bradykinin and calladin, which will trigger pain, and also they will trigger they'll trigger the positive feedback of the whole inflammatory response. Okay, so we're trying basically to initiate something that will help destroy and stop the spread of this pathogen, but the pathogen that isn't there is the reality. Okay, now you're also going to recruit leukocytes from the blood. You're going to recruit white blood cells, and the specific type of white blood cell that type 1 activated endothelial cells can recruit are neutrophils. You're going to get neutrophil recruitment. Okay, so type 1 activated endothelial cells do not have a massive repertoire of white blood cells which they can recruit, but they can recruit neutrophils. So you're going to get neutrophils being moved from the blood into the lamina propria, and this is also going to contribute to the swelling of the lamina propria. So both of these things are going to happen within the immediate phase of the asthmatic attack. You're going to get contraction of the bronchial smooth muscle cell layer, and you're also going to get swelling of the lamina propria, and both of these things are going to lead to the obstruction of the airway. You also have to remember that this is happening in all of your airways potentially, and what's the result of that? Well, it could lead to problems with breathing, okay? So it's going to cause wheezing, okay, so wheezing because you're now forcing air to be inspired and expired through much narrower tubes, and that's going to make a strange noise basically, and this noise is called wheezing. Okay, it's also going to lead to shortness of breath, okay, so you're going to feel like you need to breathe more because you're not getting enough air in basically, so you do need to breathe more. Okay, so you may well start to panic because you're struggling to breathe. Okay, and in very, very serious asthmatic attacks, this can actually lead to real problems, basically, where you're not actually getting enough air into your alveoli to have proper gas exchange, and oxygen level within the blood can fall to dangerous levels, and this is called hypoxemia, so too low oxygen levels within the blood. Okay, and this can then propagate. If it actually leads to too little oxygen being delivered to the tissues, then it's a race. Which dies first, the brain or the heart, the two essential organs, which is going to die first? Usually it's the brain. Okay, so they can be fatal. Asthmatic attacks can be fatal. Okay, so it can lead to what's called asphyxiation. So asphyxiation means death because of problems with breathing, basically, not having proper gas exchange. Okay, you can also sometimes hear asphyxiation referred to as respiratory failure. Okay, so the respiratory system is failing the rest of the body. Okay, and as I say, asthmatic attacks can be fatal if they're very severe. Okay, so that's the immediate phase of an asthmatic attack now. So that happens very, very quickly, and it's triggered by these histamine, the cysteinyl leukotrienes, and also actually although I didn't mention it, leukotriene B4. So leukotriene B4 also contributes hugely to the recruitment of neutrophils. Okay, so it's not hugely understood how it contributes to the recruitment of neutrophils, but where you have very, very high levels of leukotriene B4, you're going to end up with very, very high levels of neutrophils there also. That's an experimental fact. So this leads to increased neutrophil recruitment. Okay, right, so histamine, leukotriene B4, and the cysteinyl leukotrienes are all going to lead to this immediate phase of the asthmatic response, whereas tumor necrosis factor alpha, this final pro-inflammatory mediator that the mast cells release, is going to lead to what's known as the late phase of the asthmatic attack. So let me now discuss this with you. Okay, so what happens in the late phase of an asthmatic attack? Okay, so what will happen is the tumor necrosis factor that was secreted by the mast cells, and I suppose I should actually write its name out. So TNF-alpha stands for tumor necrosis factor alpha, and you'll often hear people refer to tumor necrosis factor alpha simply as tumor necrosis factor, and that's because even though there are other forms of tumor necrosis factor, it's easily the most important of them. Okay, so if you hear people refer to tumor necrosis factor without clarification of which one they mean, you can assume that they mean this one, the most important tumor necrosis factor. Okay, so what is TNF-alpha going to do? Well, it's going to go and activate the endothelial cells again, and it causes what's known as type 2 activation of endothelial cells. So we saw that histamine caused type 1 activation of endothelial cells. Tumor necrosis factor alpha is going to cause type 2 activation. Now, type 1 activation is extremely rapid. It takes minutes, basically, which is how it can contribute to the immediate phase, whereas type 2 activation takes hours. So not only did it take much longer to release the tumor necrosis factor alpha from the mast cells, it's also going to take much longer to actually see the effect of the tumor necrosis factor alpha on the endothelial cells. However, it will eventually cause type 2 activation, and the important thing about type 2 activation of the endothelial cells is that it's going to allow these endothelial cells to recruit a far more exciting repertoire of leukocytes, basically, so they can recruit far fancier white blood cells now. Okay, so the type of white blood cell they're going to recruit is going to be T helper 2 cells. Okay, now these T helper 2 cells are a little bit of a mystery because we've seen T helper 2 cells already in this video. We've seen them for the adaptive immune response. When we had our primary exposure, we activated T helper 2 cells, which were involved in helping the B cells to activate and produce the germinal center. Okay, however, T helper 2 cells can actually leave lymph nodes and go into the blood, and then they can be recruited from the blood into affected areas. However, we do not know where these T helper 2 cells come from. We don't know whether they are targeted against the allergen fragment we don't know if they're actually targeted against this allergen, or whether they're potentially targeted against completely different antigens, and whether they're just sort of, being recruited by these endothelial cells. Because we don't know yet how these endothelial cells would distinguish between a T helper 2 cell that's actually targeted against the allergen which caused the inflammatory response, and how they would distinguish that from a T helper 2 cell which was just against some other antigen, for instance. Okay, so there's still a little bit of a mystery here, but what we do know is that you start recruiting loads of these T helper 2 cells into the lamina propria of the bronchi. Okay, and this happens a few hours after the immediate phase, so you're going to get these T helper 2 cells moving into your bronchi. Okay, and when they get within your lamina propria, they start releasing a whole host of interesting cytokines. Okay, so they start releasing interleukin-5 is one of the things they start releasing, and also the other one is something known as granulocyte macrophage colony stimulating factor, which is also known as colony stimulating factor 2. So I suppose I should write that out at least once. So G is for granulocyte. Okay, M is for macrophage. CSF is not for cerebrospinal fluid, but instead is for colony stimulating factor. So this is the granulocyte granulocyte macrophage colony stimulating factor, which is also often referred to as the colony stimulating factor 2. Now, what do these two cytokines, or pro-inflammatory mediators, lead to? Well, they're going to lead to the recruitment of a new type of leukocyte from the blood, and these are dangerous. These are going to lead to the recruitment of a really quite dangerous cell within the immune system. So we're going to start recruiting a type of leukocyte called an eosinophil. Okay, so this is a type of granulocyte. Okay, so there are 3 types of granulocytes: neutrophils, eosinophils, and basophils as well. Okay, now eosinophils are a dangerous cell. So let me draw one down here. So they are called eosinophils because they take up the dye eosin very well. Now eosin is a red dye, so when you stain them with eosin, they appear bright red. In addition, they have this odd-shaped nucleus here, where they have a bilobed nucleus. So the nucleus has this odd structure where it has 2 lobes connected by a tube between the 2. Okay, so let me colour this in. So the cytoplasm, when stained with eosin, will appear bright red, and then the nucleus has this bilobe structure. For this reason, hopefully you can see what this is starting to look like. Basically, they're often compared to a sunburnt, sunglasses-clad face, basically, because the nucleus looks like a pair of sunglasses, and then the cytoplasm just looks like sunburn, basically. Okay, so that's what they're often compared to as, so you'll be able to distinguish those cells next time you're in histopathology. Okay, and basically, these are a really dangerous cell. They are the cell which your body uses if it has a multicellular parasite within it. Okay, so if it's got a massive great worm that it wants to get rid of, the only cell in the immune system that stands a chance of dealing with it is these eosinophils. So they have deadly tricks up their sleeve. So they are a granulocyte, and they're called a granulocyte for a reason. So they are full of these granules, basically. So they have lots of little granules, which are just vesicles containing certain molecules within them. And the molecules that are within these granules, let me give you their names. Okay, so there are 2 major proteins that are within these granules, and one is known as major basic protein. Okay, which is also often abbreviated to MBP. The other is known as eosinophil cationic protein. So eosinophil cationic protein, which is often abbreviated to ECP for short. Okay, so eosinophils will release eosinophil cationic protein and major basic protein, and these are just cytotoxic, basically. They are really poisonous to cells. So this is how they kill parasites. They get on top of them and they release these foul granules containing these cytotoxins on top of these cells of the multicellular parasites, and those toxins will just gradually kill the cells of the parasite, okay? Right, so granulocyte macrophage colony stimulating factor and interleukin-5 are going to lead to the recruitment of these eosinophils. Now again, the way in which they lead to the recruitment of the eosinophils is not well understood. What we know, and the observed fact, is that if you have an area of interstitial fluid that has a very high level of interleukin-5 and granulocyte macrophage colony stimulating factor, you end up with a huge number of eosinophils there. Okay, that's the experimental fact. How is a bit more difficult, okay? So, basically, we don't think the granulocyte macrophage colony stimulating factor and the interleukin-5 work on the endothelial cells of the microvasculature. Okay, we don't think that it induces some change on the endothelial cells, which then allows the recruitment of the eosinophils into the interstitial fluid. Instead, we think they actually act on receptors on the eosinophils themselves. So they seem to activate the eosinophils, which are coming through the microvasculature, so that the eosinophils can then move across the membrane. Okay, so the eosinophils, however they're recruited, are recruited into the lamina propria. Okay, so you end up with a huge number of eosinophils infiltrating into the lamina propria. Now this is bad news, because remember, these are incredibly deadly, and they are being brought here for some silly allergen, okay? So they're not going to be impressed. Right, the same molecules which recruit them here, this granulocyte macrophage colony stimulating factor and interleukin-5, which recruit the eosinophils to the lamina propria, they're also going to activate the eosinophils. So the eosinophils start releasing these granules which are full of these horrors. Okay, so they start releasing eosinophil cationic protein and major basic protein into the interstitial fluid of the lamina propria. Okay, now this is not good at all. Okay, so these are incredibly cytotoxic molecules which are being secreted into the lamina propria. Okay, and what's going to happen is this eosinophil cationic protein, the major basic protein, are going to go and work on the the epithelial cells here, and they're going to kill epithelial cells. So in this late phase of an asthmatic attack, you get the damage to the bronchi, basically. The epithelia are getting damaged, basically. The epithelial cells will gradually wear away. So every time you have an allergic asthmatic attack, you are getting one of these late phases where eosinophils are killing your epithelial cells. Okay, and what this can gradually lead to is so much damage to the epithelium that neurons, sensory neurons within the lamina propria, okay, so let me show this. Let's put a sensory neuron in here. Sensory neurons in the lamina propria can end up exposed to the airway, basically. And then when you breathe in things like cold air or environmental pollutants or toxins in cigarette smoke, this can activate these sensory neurons, and then these sensory neurons can now stimulate an asthmatic attack. So they can stimulate the two portions of the immediate phase. They can trigger contraction of the bronchial smooth muscle cell there, and they can also trigger neurogenic inflammation, so they can activate the endothelial cells to initiate the acute inflammatory response. So they'll initiate vasodilatation, endothelial cell contraction, and leukocyte extravasation, so that you get the swelling of the lamina propria, and both of these things are then going to cause the obstruction of the airway. So this is how allergic asthma can eventually lead to non-allergic asthma. Okay, however, some people get non-allergic asthma right from the beginning, and this still doesn't explain things like how stress and anxiety can trigger an asthmatic attack. Okay, so non-allergic asthma, as I say, basically anything that isn't allergic asthma is grouped together as non-allergic asthma, but really it's not just one disease. There are a whole bunch of different pathologies there for the different types of non-allergic asthma. Okay, it's just things that we don't understand really that well. Okay, so that now concludes what happens within an asthmatic attack. What we'll talk about in the next video is firstly the rebuilding of the IgE, because obviously from what I've told you so far, IgE would eventually go down, okay? So IgE binds to the Fc-epsilon-R1 receptor on the surface of the mast cells and stays there for months, but it doesn't stay there forever. It will eventually leave. So you need to restart the adaptive immune system and create more IgE if you're going to keep up having asthma, basically. So you need to maintain your level of IgE if you're going to maintain being asthmatic, having this allergic response to this allergen. So we'll talk about the fact that every time you are exposed to the allergen, what it's going to do is set off the adaptive immune system all over again and produce more IgE, basically. So we're going to talk about B memory cells and T memory cells, but we'll do that in the next video.